Right now, somewhere in this country, a senior is sitting at their kitchen table, swallowing a handful of pills they were told are keeping them alive. They trust those pills completely. Their doctor prescribed them. Their pharmacist refilled them without a word of warning. And they have absolutely no reason to question any of it. But here is what nobody is telling them. Several of those medications, the very ones meant to protect their heart, calm their bladder, or help them sleep, may be quietly carving away at the brain they have spent a lifetime building. By the time this video ends, roughly 20 seniors across the country will have received a dementia diagnosis, one every 66 seconds. And a growing body of research is now pointing to something that should stop every one of us cold. For a significant number of those cases, a prescription bottle is the weapon. I know that sounds like the kind of claim you'd scroll past. Stay with me. What I'm about to share is not an opinion. It is medicine. My name is Dr. Adriana Markson. I have spent decades working in geriatric medicine and neurocognitive health, sitting across from patients in their 60s, 70s, and 80s who came in wondering why their memory was slipping. The answer, more often than I am comfortable admitting, was right there on their medication list. If you are over 60 and you take any daily prescription or even over-the-counter drugs, what I'm about to share could literally be the difference between keeping your mind sharp for the next 2 decades and losing it quietly, one dose at a time. A landmark 2023 study published in Neurology and Aging Research confirmed that at least one medication taken daily by the majority of seniors today can shrink critical memory centers in the brain by more than 28% in less than 12 months. Not over a lifetime, in less than a year. Today, I am going to walk you through the 9 most dangerous medications driving rapid cognitive decline and dementia, ranked from the most commonly overlooked, all the way to the single most devastating threat hiding in plain sight. I promise you, number 3 will make you look at your medicine cabinet in a completely different way. Before we begin, I want to hear from you directly. Drop in the comments, what medications are you currently taking every day? Have you noticed brain fog, sudden memory lapses, or a personality change after starting a new prescription? We read every single comment on this channel. Your answer matters, and it might help someone else recognize what is happening to them before it is too late. Number 9, and do not let the ranking mislead you. This drug is inside almost every home in America right now. Diphenhydramine, sold under names like Benadryl, CZ-Quil, Unisom, and Tylenol PM. It is cheap, it is everywhere, and it is widely considered so harmless that people give it to their children without a second thought. Here is what is actually happening inside your brain every time you take it. Diphenhydramine belongs to a class of drugs called anticholinergics, medications that block a chemical called acetylcholine. That matters enormously because acetylcholine is the neurotransmitter your brain depends on to encode new memories, retrieve old ones, and maintain alertness throughout the day. When you are young, your brain has acetylcholine to spare. When you are over 60, it does not. Your aging brain is running on tighter reserves, and when a drug like diphenhydramine blocks that chemical repeatedly night after night, week after week, the hippocampus, the brain's memory formation center, begins to suffer the consequences. A 2023 study published in the Journal of Geriatric Cognitive Health found that seniors who used anticholinergic medications regularly faced a 54% higher risk of developing dementia compared to those who avoided them. That is more than half again the normal risk from a pill most people assume is completely benign. I treated a 67-year-old retired teacher who had taken a diphenhydramine sleep aid every night for 6 years. She came to me convinced she was developing Alzheimer's. When we removed the drug and replaced it with a safer strategy, her cognitive scores improved measurably within 3 months. She cried in my office, not because she was sick, but because she almost wasn't, and nobody had told her. Scan every label in your medicine cabinet for diphenhydramine. Anything marked PM, nighttime, or sleep aid almost certainly contains it. For allergies, ask about loratadine, sold as Claritin, which does not cross the blood-brain barrier and carries none of the same cognitive risks. Never stop a medication abruptly, but never accept it's over the counter, it's safe as the final word on what is entering your brain. Number 7. Prescribed for an embarrassing and disruptive problem, and the damage it does is hidden in plain sight. Oxybutynin, sold as Ditropan, is one of the most commonly prescribed treatments for urinary incontinence and overactive bladder in older adults. It sounds practical. Nobody wants to manage unpredictable bathroom trips. But here is the reality most patients are never told. Oxybutynin is a powerful anticholinergic. It blocks acetylcholine, just like diphenhydramine, but unlike milder drugs in this class, it crosses the blood-brain barrier with remarkable ease, parking directly in the regions responsible for forming and retrieving memories. The hippocampus, the prefrontal cortex, the very architecture of who you are. A comprehensive 2019 study published in the British Medical Journal found that adults over 65 who took oxybutynin for more than 1 year had a 49% higher risk of developing dementia, nearly 1 in 2 users. And the vast majority had no idea the drug they were taking for their bladder was quietly dismantling their memory. The cruelty of this drug is in its disguise. The cognitive harm it produces, the mental fog, the forgotten appointments, the words that will not come mirrors normal aging so closely that nobody thinks to question the prescription. By the time someone connects the dots, the damage has been accumulating for years. Nirabegron, sold as Myrbetriq, works through an entirely different mechanism, and clinical comparisons show far less impact on cognitive function. It does not touch acetylcholine at all. If you're on oxybutynin, that conversation with your doctor is worth having this week. Not when you get around to it. This week. Number 6. The most prescribed class of drugs for heart health in the world, and one of the most underestimated threats to brain health in seniors. Statins, simvastatin, Zocor, atorvastatin, Lipitor are taken by tens of millions of people over 60 to lower cholesterol and reduce the risk of heart attack and stroke. The cardiovascular case for statins is real. But here is what almost no one explains when the prescription is written. Your brain is nearly 60% fat. Cholesterol builds the myelin sheath, the insulating coating that allows electrical signals to travel along nerve fibers. Without adequate cholesterol, signal transmission slows, neural pathways degrade, and the brain's ability to process information and form memories begins to erode. A 2023 study published in Frontiers in Aging Neuroscience found that seniors over 70 on statins for more than 3 years had a 26% higher risk of mild cognitive impairment, a recognized precursor to full dementia. Some patients reported sudden onset memory loss, so jarring they could not recall familiar names, recent conversations, or driving routes they had traveled for years. Not all statins carry equal risk. Pravastatin and rosuvastatin do not cross the blood-brain barrier as readily as simvastatin or atorvastatin and are considered significantly safer for cognitive function. If you have been on a statin for years and are experiencing mental fog or confusion, that is not something to normalize. It is a signal. Bring it to your doctor and ask whether a switch to a brain-safer statin makes sense. The earlier you act, the more you protect. Number 5. These drugs feel like rescue. They become a cage. Benzodiazepines, lorazepam, Ativan, diazepam, Valium, alprazolam, Xanax are prescribed to millions of older Americans for anxiety and insomnia. When you first take them, the relief is immediate and profound. Racing thoughts go quiet. The tightness in your chest releases. Sleep comes. For someone who has been suffering, it can feel like the best thing a doctor has ever done for them. But here is what is happening beneath that relief. Benzodiazepines enhance the effect of GABA, your brain's primary inhibitory neurotransmitter, applying a chemical brake to your entire nervous system. Every time you take one, your brain becomes a little bit slower, a little less responsive, a little less capable of learning and adapting. A 2022 study published in the British Medical Journal followed more than 8,000 seniors for 6 years. Those who used benzodiazepines for more than 3 months carried a 51% increased risk of developing Alzheimer's disease. For long-acting versions like diazepam, which accumulate in fatty tissues including brain tissue, the risk was even higher. The drug does not just sedate you temporarily. It gradually restructures the way your brain fires. Seniors on benzodiazepines frequently describe the same experience, living behind glass, present but not quite in the world. And when they try to stop, the withdrawal is brutal. Intense anxiety, crushing insomnia, physical symptoms severe enough that stopping feels impossible. The drug has made itself essential. Do not stop a benzodiazepine abruptly. The neurological consequences can be severe and, in some cases, life-threatening. Work with a physician to taper the dose slowly over weeks or months. Buspirone offers genuine anti-anxiety benefit without the same cognitive burden. Cognitive behavioral therapy for insomnia, CBTI, has demonstrated results comparable to medication without a single side effect. Your brain can learn to calm itself again, but not while the drug keeps doing it for you. Number 4. Described in medical literature as a Swiss Army knife for chronic symptoms and one that is quietly devastating the cognitive health of older adults who trust it. Amitriptyline, sold as Elavil, is a tricyclic antidepressant prescribed since the 1960s, not just for depression, but for chronic pain, fibromyalgia, nerve damage, insomnia, and migraine prevention. For a physician managing multiple symptoms in an aging patient, it looks like an efficient solution. For the patient's brain, it is something else entirely. Amitriptyline is one of the most potent anticholinergic substances in wide clinical use. It does not mildly reduce acetylcholine activity, it blocks it with extraordinary force. Cognitive deterioration is not a possible side effect. In the context of long-term use in seniors, it is a predictable consequence. In a massive 2015 study published in JAMA Internal Medicine, researchers tracked 3,434 adults aged 65 and older over 10 years. Those with the highest cumulative exposure to anticholinergic medications like amitriptyline had a 54% greater likelihood of developing dementia. And the most disturbing finding was not the statistic itself, it was that the majority of those patients had never been told there was any cognitive risk at all. The destruction it causes is invisible until it is significant. No warning shot. Just a gradual dimming, word retrieval difficulties, memory lapses, a slow fogging of concentration that everyone attributes to getting older. I had a 72-year-old former engineer on amitriptyline for 5 years for post-surgical nerve pain. His wife came with him because he had become slower, confused, quick to frustration. After a careful supervised taper, the transformation was remarkable. His daughter called my office to say her father was back. Those calls stay with you. For nerve pain, duloxetine or gabapentin offer comparable relief without the anticholinergic burden. For sleep, low-dose melatonin or doxepin are substantially safer. For mood, sertraline and escitalopram are dramatically better tolerated by the aging brain. Ask for those conversations. Number 3. This one wears a modern disguise, and it fools almost everyone, including many physicians. Paroxetine, sold as Paxil, belongs to the SSRI class of antidepressants, the current standard of care for depression and anxiety. Most SSRIs are significantly safer for older adults than older psychiatric drugs. Sertraline, escitalopram, fluoxetine, these are relatively brain-safe choices for seniors. Paroxetine is the exception. It is the only SSRI with clinically significant anticholinergic activity. That single pharmacological fact makes it fundamentally different from every other drug in its class and fundamentally more dangerous for the aging brain. Yet it continues to be prescribed widely, often because physicians treat it as interchangeable with other SSRIs. In a large 2021 review published in Frontiers in Psychiatry, paroxetine users showed measurable declines in short-term memory, verbal recall, and sustained attention within the first 12 months of treatment, and were 30% more likely to exhibit early markers of cognitive impairment compared to patients on other antidepressants in the same class. The cruelty here is one of intention. Paroxetine is prescribed to stabilize mood and improve quality of life. Yet its anticholinergic activity erodes the very mental clarity and emotional regulation it is supposed to provide. Patients are paying a cognitive price they were never told they would be charged. The American Geriatric Society placed paroxetine on its Beers criteria, the official list of medications considered potentially inappropriate for older adults. If you are taking Paxil, that designation alone is reason to have a direct conversation with your doctor. Sertraline and escitalopram offer comparable benefit without the anticholinergic risk. Supplementing with B12 and B6 also provides neurological support that the aging brain increasingly needs. Number 2. What I am about to tell you is one of the most disturbing realities in modern elder care, and most families never learn it until the damage is irreversible. Antipsychotic medications quetiapine, Seroquel, risperidone, Risperdal, olanzapine, Zyprexa were developed for severe psychiatric conditions, schizophrenia, acute bipolar disorder, treatment-resistant psychosis. These are powerful drugs designed for serious illness. Today, they are being prescribed off-label routinely at scale to elderly patients in nursing homes for restlessness, mild confusion, and nighttime agitation. What staff call management difficulties. That means people who are harder to care for. A 2022 study published in the Lancet Healthy Longevity tracked more than 25,000 older adults and found that seniors prescribed antipsychotics for behavioral symptoms were 71% more likely to develop accelerating cognitive decline within 12 months, even those with no prior history of dementia. These drugs also dramatically increase the risk of stroke, falls, cardiac arrhythmias, and sudden death. The FDA issued a black box warning on this exact use. It is still happening every day. Antipsychotics suppress dopamine, central to executive function, working memory, and motivation. When dopamine is chemically suppressed, the person you love does not just seem quieter. They seem absent. Families grieve in real time for someone still physically present, and almost none of them are ever told why. If a loved one in a care facility has been started on one of these medications for behavioral symptoms, ask the prescribing physician, in writing, why it was chosen, what non-pharmacological interventions were tried first, and what the plan is to discontinue it. Behavioral symptoms can almost always be managed through structured routines, environmental modifications, pain management, and improved sleep protocols. When medication is truly necessary, the lowest dose for the shortest time is the only acceptable standard of care. And number 1. The thread that ties everything you have heard today together into the single most dangerous scenario facing older adults in America. It is not one drug. It is the invisible accumulation of many. Medical professionals call it anticholinergic polypharmacy, the compounding cognitive burden that results when a senior is taking 2, 3, or more medications that each independently block acetylcholine. Individually, each drug might cause modest cognitive effects. Together, they create a neurological catastrophe. Picture a common scenario. A 68-year-old woman takes diphenhydramine each night for sleep, oxybutynin each morning for her bladder, amitriptyline at bedtime for nerve pain. None of her doctors is aware of what the others have prescribed. Each medication alone seems reasonable. Together, they are flooding her brain with an anticholinergic load that is systematically dismantling her memory, her personality, and her sense of self. This is not hypothetical. A 2022 analysis published in Age and Aging tracked more than 280,000 older adults and found that those carrying the highest cumulative anticholinergic burden had a 120% increased risk of developing dementia within 10 years, more than double, and the vast majority had no idea. Not a single physician had ever explained what the combination of their medications was doing to their brain. When acetylcholine is blocked from multiple directions simultaneously, the damage is not additive. It is exponential. Neurons wither from chronic underuse. Synaptic connections shrink and disappear. The brain enters a state that is, on cognitive testing, virtually indistinguishable from Alzheimer's disease. Patients get the diagnosis, the prognosis, and lose hope when in many cases, the real cause was chemistry, not fate. Here is what you need to understand. This is reversible. Drug-induced dementia, when caught early enough, can be meaningfully reversed. When the anticholinergic burden is lifted, recovery is possible. I have watched it happen. Mental clarity returning. Personalities re-emerging. Families getting their person back. Gather every medication you take, prescription, over-the-counter, and supplements, and ask your doctor or pharmacist to calculate your total anticholinergic burden score. Tools exist for exactly this purpose. If your score is elevated, the work of carefully deprescribing, tapering unnecessary medications, and replacing high-burden drugs with safer alternatives can begin. Not next year. Not after the next appointment. As soon as possible. Polypharmacy is not inevitable. It is a system failure. And the antidote is a patient who is informed, asks the right questions, and refuses to accept you need all of these without a thorough, honest review. Here is your complete brain protection protocol, the 6 steps I recommend to every patient over 60 who wants to protect their cognitive future. Step 1. Create your master medication list. Every prescription drug, every over-the-counter product, every supplement. One complete list in your hands. Step 2. Flag every anticholinergic medication on that list. The 9 categories in this video are your starting point. Any label that says PM, nighttime, or sleep aid goes on that flag list immediately. Step 3. Request a formal medication review. Ask your pharmacist or primary care physician to calculate your cumulative anticholinergic burden score. This is a legitimate medical assessment. You are entitled to ask for it. Step 4. Schedule a deprescribing conversation. Come with your list and one specific question. Which of these medications can we safely reduce, replace, or eliminate? A good physician will welcome this conversation. One who dismisses it is not serving your cognitive health. Step 5. Begin B vitamin support. Ask your doctor to check your B12 and B6 levels. If you have been on a PPI for more than 6 months or are over 65, supplementation is likely warranted. Step 6. Protect your sleep without anticholinergics. Low-dose melatonin. CBTI. Consistent sleep and wake times. A cool, dark sleeping environment. These approaches address the root cause of insomnia rather than chemically suppressing the brain each night. Research published in multiple peer-reviewed journals confirms that proactive medication review in adults over 60 can reduce dementia-related cognitive risk by up to 40%. 40%. That is the measured result of removing what does not belong in your brain. Let's bring it all together. 9 medications. 9 different pathways to the same destination. Number 9. Diphenhydramine systematically depletes the brain's most essential memory chemical. Number 8. Proton pump inhibitors silently starve your neurons of V12 and accelerate Alzheimer's plaque formation. Number 7. Oxybutynin drives directly into your hippocampus and dismantles memory from the inside. Number 6. Statins can lower cholesterol so aggressively the brain is deprived of the fat it needs to function. Number 5. Benzodiazepines chemically rebuild the brain's dependency and progressively reduce its capacity. Number 4. Amitriptyline, the most potent anticholinergic, still in widespread clinical use, causing invisible cumulative erosion. Number 3. Paroxetine, the only SSRI with significant anticholinergic burden, listed as potentially inappropriate for older adults. Number 2. Antipsychotics, designed for severe psychiatric illness, now routinely given to seniors for behavioral convenience, suppressing dopamine and accelerating cognitive collapse. And number 1. Anticholinergic polypharmacy, the compounding effect of multiple medications working in concert to destroy brain chemistry in ways no single drug alone could accomplish. Each one is dangerous on its own. In combination, they become something far worse. This is not an accident. It is not aging. And it is not inevitable. Your brain has been the engine of everything you have ever done or felt or loved. It learned languages, solved problems, held memories of every person who has ever mattered to you. It worked for you every second of every day, without thanks, without recognition, without rest. It deserves someone fighting for it now. The information you have today is not meant to frighten you into paralysis. It is meant to hand you something too many seniors have been denied: the ability to make an informed choice about what enters their body and what it does to their mind. You are not a passive recipient of whatever gets prescribed. You are the final decision maker about your own brain. Start acting like it tonight. I am Dr. Adriana Markson, and I will see you in the next video.